So I want to bring out Dr. Rob Watkins, who's the director at Marina Spine Center, as well as Dr. John Yoon, who is a professor of neurosurgery and orthopedic surgery at the University of Pennsylvania. I've asked these two speakers to discuss a topic that I think we all see in our offices all the time, whether it's a high-level athlete or a recreational athlete, and the question is fusion versus motion preservation. And I've asked Dr. Yoon to defend the case of cervical disc replacement, and I've asked Dr. Watkins to defend the case of ACDF. Both of our speakers here today have performed these procedures on professional athletes that you all know. And so I'll present this case, and then I'll ask them to kind of defend their respective position. And I want this to be really an interactive session, so please, if you have questions, come up to the microphones and participate in the discussion. So the case is a 25-year-old hockey player with 2 months of left arm pain and weakness. Started during a wrist shot, pain in the left C6 distribution, and has not only pain, but also numbness and a neurologic deficit. No signs of myelopathy, and he's otherwise healthy. He's failed conservative measures. And on exam, he does already have some subtle supraspinatus atrophy. He's got diffuse sensation and a C6 distribution and some biceps and wrist extensor weakness. These are his radiographs, and so they show he's got disc degeneration that's fairly isolated at the C5-6 level with mild kyphosis at that level, and there's preserved motion on the flexion and extension views. His MRI shows a large left-sided paracentral disc herniation at the C5-6 level with some bony changes as well, so it's a combination of a soft disc as well as some spurring from the uncovertebral joint. CT scan shows he has normal facet joint anatomy. So this is the case, okay? And I'm going to ask Dr. Yoon first to offer his opinions on why he would offer a CDR, and then ask Dr. Watkins why he would recommend ACDF. Just to put this in the rubric that Dr. Zuckerman talked about earlier, this is a high-impact, high-frequency athlete, so he falls in that level 4 category that we presented before.
Looking at this case, I know I'm defending CDR, but there is a motion-preserving operation that's been around for longer, which is a posterior foraminotomy. And immediately that sort of came to my mind because this disc is very off to the foramen. It is broad base, but it's favorable for doing a foraminotomy. So in my hands, I probably would have done a posterior foraminotomy with the endoscope. My second choice would have been the cervical disc replacement. The kyphosis is not a contraindication. He's got well-preserved motion at that level. And then the hockey players, they need all the range of motion in terms of rotations, flexion extensions. So, and in a young person with a unilateral symptom, I think the CDR is a better choice over the ACDF.
Just a show of hands, who would offer this patient a foraminotomy versus an anterior-based procedure? Fair number. I purposely tried to select a case. I don't think I did a good enough job selecting a case where the disc kind of went over fairly to midline, trying to weed out the foraminotomy camp, but I guess I didn't do a good enough job at that. Dr. Watkins, why would you perform an ACDF in this patient?
So realistically, this is kind of the ideal case where you could do all 3 of those options and have a 90% success rate. And do you make anything of Wellington and Mai's paper about in professional athletes where they looked at foraminotomies versus ACDFs and showed foraminotomies have a higher return to play and faster, but ultimately there was like 46% ended up needing a secondary surgery at that index level. I think that's too high of a number. It was basically based on an internet search, but 46% is a lot. If you counsel a professional athlete, there's a 46% chance and you may have to have it reoperated on with the foraminotomy. Most people aren't going to take that option. Do you have any opinion about that?
Yeah, but I think that 46% is kind of laid over the entire career. It may not be the playing career. So if you can delay that, if they get a surgery when they're retired, maybe when they're 50s, I think that's okay. I think the downside of getting an anterior operation here is that they end up with a foreign body. So even if the TDR is great at preserving the adjacent segment, there's still a risk. ACDF, I think it definitely, limited range of motion. You're going to take away the motion at 5'6", which is a majority of the motion segment. And then I think you put him at the risk of developing an adjacent segment sooner than the TDR.
One other question is, if you did the framenotomy and the symptoms came back in a year, would you do an ADR after a framenotomy?
Yeah, I don't think there's a contraindication. Obviously, I think it depends on what the imaging looks like afterwards. But yes, I don't think the framenotomy rules out anterior operation.
Yeah. And in our experience, I've worked with my dad, who's been doing spine surgery for 50 years in athletes, and we operated on Peyton Manning when he had a framenotomy in the back and then had a weak arm, and we did an ACDF in him, which has probably caused a resurgence of neck fusions in the general population because everybody said, well, look, he won a Super Bowl afterwards, a fusion must not be that bad. In our practice, we probably do 80 to 85% artificial disc replacements in normal people. We rarely really do fusions, we've done an artificial disc replacement in 3 UFC fighters, a baseball player, an NFL player, but we've also done a lot of fusions. And basically where it comes to now, I think they're all good options. The artificial disc is very stable. As we get more experience with artificial discs in the general population, I think I saw something recently said 100,000 cervical artificial discs are done a month in America these days. And so once we get up to like the 2 to 3 million of cervical artificial discs done in the worldwide population, and we see that weekend warriors and people skydiving and jumping out of airplanes and getting in car accidents are not having a fractured dislocation at the artificial disc and ending up paralyzed, that gives us more data and more security to recommend it in high-impact athletes. But a fusion's a solid surgery. A fusion has an 80 to 85% return to play. The most NFL careers last about 3 years, so generally they're going to make it at least 3 years before getting adjacent level issues. And so a fusion, the reality is all three of them are good surgeries. Fusion's a very stable, solid surgery with good, solid outcomes. The artificial disc, we do in a lot of people. The only athletes right now that an artificial disc is not really recommended is an NFL player. And if you've ever been on the sidelines in an NFL game, like Dr. Fear was talking about, the head-to-head inherent driving contact to gain an extra inch is the most violent collision you've ever experienced when you're down there. And so doing an artificial disc in a football player has not really been done. I'll tell you as a side note, I actually did one in an NFL kicker, and he's well informed. It's what he wanted. I did it like 3 to 4 years ago. He's a kicker. So I basically said, okay, well, you can get an artificial disc. I use a Pro Disc C, pretty solid device. And I said, but if you're the last man standing, you are not allowed to lower your head, period. And you can say that to players, but I've had players in the heat of the moment, if the playoff game is on the line, that kicker's going to lower his head still. So no matter, we think positions matter. They kind of do. Linebackers, defensive backs are worse, but any position may have to lower their head to gain that extra inch at any point of a game. So you got to be prepared for that. And so this NFL kicker that I put it in, because he was older, that's what he wanted done. I thought it was relatively safe. No team would hire him. He even went to the XFL. The XFL wouldn't hire him because they probably had somebody else that was similarly skilled who didn't have an artificial disc in the neck. They didn't have to worry about it. So it's not only what you think you're comfortable, it's what's the league's comfortable with, who's paying the bills, who's taking the liability, what are they comfortable doing? And a single level fusion, everybody knows what that is. Everybody's comfortable with that. An artificial disc is gaining more popularity. It's a great option, but there's still some unknown risk. Which artificial disc are you going to put in? I love the Simplify artificial disc. Can you tell a player that that's not going to dislocate? It's solid as can be. They all have their own limitations. Pro Disc C is solid. It's got about a 30% HO rate at times. So it's not like we got the perfect artificial disc implant that we know is going to work. And so there's still a lot of grays on that.
Yeah, I think the idea of a constrained versus a non-constrained implant, which is really, not super well defined, actually between the different implants, but certainly some of them are potentially more likely to become hypermobile and create issues, in these types of athletes. Dr. Yoon, how do you think about that? You've had experience with artificial discs in some of these, level 4 athletes, high impact, high frequency. How do you think about the type of implants that you recommend?
Yeah, I don't think there's a good data yet, whether you put a constraint versus non-constraint, and whether that has a clinical meaningful impact. I mean, all these devices do go through, biomechanical studies, and they're subject to 10 million cycles in order to pass that, sort of bar. And so, Mobi C's, Simplify, Pro Disc, Prestige, all these devices are sort of cleared through that. The 10 million cycle is a sort of an arbitrary number. is I think on average, healthy adults go through about 5 million cycles per year. So if we're talking about really 2 years of data to go off of, but we certainly do not have any data on these high impact athletes, whether the creating a keel really makes a difference. I have put in athletes non-constraints or less constrained TBRs. They done just as well as the one that had a more constrained, like simplified pro disc. So I don't think the data is there. But in a level 4 athletes, I think I would prefer a more of a little bit constrained device.
Just to conclude this case, so I did use a Pro Disc C in this athlete, and he rehabbed, he did well, recovered his strength. He was allowed back to full contact play after he had made a full neurologic recovery and had painless range of motion. I think just to close this out, as more and more centers enroll in ASR and we collect more data about these implants and more long-term data, as in the orthopedic world has been done in total joint replacements, I think we'll know more about these devices and their longevity, and hopefully we'll get more information on which is best in what type of patient. So thank you both.
Thank you.
Good.